We are back to talk about tubal ligation.
Hey, friends.
I got Dr. Valieva back with me. We are on call today at the hospital.
It's going to be a fun night.
It's going to be a fun night.
I'm trying to talk Eric into doing a podcast in the morning after our call shift to see how terrible it's going to be, so stay tuned.
We'll see if we do that.
I'm excited.
Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and today I have with me, as I said, back by semi-popular demand, Dr. Valieva. Please consider downloading and following along. We are on all the major podcast hosts, and check us out on YouTube for the video podcast. And as we discussed, we're going to talk about tubal ligation, as it is well known, but also technically more so female permanent sterilization today is what we'll be concentrating on as one of our surgery consult series. And again, we have Dr. Olga Valieva. We practice here in the Pacific Northwest. She did her undergrad in...
Sorry.
Silence your phone. At University of Washington, Pacific Northwest University for med school, and with me at Aurora Healthcare in Milwaukee for residency. What we'll cover today, what is permanent sterilization? What options are there? Risks and benefits, as always. A walkthrough of the surgical procedures as we discuss them. Are there any complications or consequences or other common questions? And maybe some clinical scenarios.
Mm-hmm.
So, young Dr. Valieva.
Oh, I'm young now.
I have a couple. Well,
you seem so far away today. I don't know if I like this.
I have a couple of clinical scenarios for you.
Let's hear them.
Okay. We're talking to patients in the clinic in these scenarios, but you have a 24-year-old female. She's certain she doesn't want kids.
Mm-hmm.
Has tried multiple options for contraception. That includes maybe things like birth control pills, even IUD, and it has not worked. And so she's coming to talk about her options. Well, next scenario, we have another 24-year-old female. She is certain she doesn't want kids. She's pursuing a career in medicine.
Good on you.
And believes that having kids may disrupt this. And is so wanting to discuss her options. 45-year-old with a Mirena IUD who wants to take a break from hormones. She doesn't want any more kids. And... she is interested in the idea of permanent sterilization and taking out the IUD. So let's keep these in mind as we talk about permanent sterilization. And so, how common is it?
You know, I actually don't know the statistics, but it is the most common birth control in the world. I'm terrible at OBGYN.
It's okay. Well, in reproductive age females who use contraception, about 25% of them use permanent sterilization. That is in stark contrast to the young gentlemen of the world who, again, same demographic, reproductive age men who use contraception, only about 5% of them contribute with their vasectomy.
Is that in the U.S. or worldwide?
That's U.S.
Okay,
numbers.
worldwide data is a little different, I feel like.
That is U.S. numbers, I believe.
Men and their testicles.
Men and their testosterone. We have so much. Kind of give us an overview of what kind of options we have to do a permanent female sterilization.
Awesome. So female sterilization involves some level of cutting, burning, clipping, tying off of the fallopian tubes. So the fallopian tubes are the little connection between the ovary and the uterus where the sperm and the egg actually meet, and that's where fertilization happens. And so the goal of this sterilization is to prevent the sperm and the egg from meeting by blocking said fallopian tube. So recently there was a newer procedure. It was called Escher sterilization, which has since been discontinued.
Escher.
Potato, right. Just because it had so many other issues and side effects and complications, but that essentially caused a blockage in both the fallopian tubes. We no longer use that. It was a kind of a pain to do.
Oh, I loved it.
Really?
The procedure of it, because you don't have to go into somebody's
sure, but
abdomen,
is
which is we'll talk about here in a second.
okay.
But it was kind of a fun little hysteroscopic procedure.
Yeah, I guess.
Bad that it
was alright.
caused issues.
So
but,
many issues. But the more common ones would be tubal ligation, either postpartum, immediately postpartum, a few weeks postpartum, or just in a random time period in someone's reproductive life cycle. We typically cut our ligate clip both fallopian tubes unless somebody has already had one that was taken care of or damaged by another reason, since we want both of those tubes clipped. And we do them either laparoscopically, which I guess we do most of the time on an outpatient setting, or if somebody's having a delivery like a cesarean section, we do them during their cesarean section. The procedure in and of itself is not very long. The fallopian tubes are pretty tiny, so it doesn't take long to cut them or ligate them. I would say maybe 5 minutes tops of the actual poking around in there, Eric, right? And then, but
I'd say for whole procedure, like 20 to 30 minutes.
Yeah,
That's probably
pretty
generous.
quick. Maybe on a slow day.
Never in a rush. Never in a rush we are. Yeah. So bunch of different methods, but I would say by far a majority of us practitioners, OBGYNs, are, if it's the interval tubal sterilization, so it's not immediately postpartum, we're doing the salpingectomy, and that's been a huge shift over the last 5 to 10 years.
Yep. So recently we've been removing the entire fallopian tube, or both the fallopian tubes, because we found that for some populations of women, it actually reduces the risk of them getting ovarian cancer by a huge percentage. So we are offering that as an option to women, and I would say most people go for that option. Previous to this, we would either clip them with a device called Filshy clips. They're little metal inert clips. Yep. And then we would put them kind of in the middle of the fallopian tubes, and they would both obstruct and also then kind of kill off the segment and separate the fallopian tubes. Or we would burn the tube completely with electric cautery, or put a little ring or tie them off.
I've never done the ring.
I've never seen the ring.
Yeah.
Only in a textbook.
Yeah.
I heard it was a thing, though.
Earlier in our residency, we had some providers that did the burning, and so I've done that. We've done the clips, but I haven't done that in a good amount of time.
And they're effective, but slightly less effective. So the risk of pregnancy after those was still about 5 in 1,000. So there was a potential risk of, pregnancy. Some of them even range as high as 20 to 30 out of 1,000. We don't have the same data for the salpingectomy removal of the tubes, because we haven't done a lot of longitudinal data analysis.
It hasn't been around long enough.
It hasn't been around. So, but we're thinking it's pretty close to non-existent risk of pregnancy. But
because I think the CREST study, which really looked at comparing a lot of these things, that was done over like a 14-year time period. And so there's only been like 5 years of like consistent data. Yeah. So we will learn eventually, but it's been working really well. I think a good benefit to it is saying like, oh, why would you want your tubes out too? Yes, it might reduce the risk of future ovarian cancers, but the fallopian tubes can also cause other problems too, throughout someone's life. And if someone has decided they don't want any more kids and they're going to have the procedure, in my eyes, it's just a lot. Makes sense to just remove them. Can grow cysts, infections can be there, can dilate or cause pain. So anyway, in my eyes, I like doing it that way.
Yeah. And it's reliable. It's permanent. You don't have to think about it. It's done. You're good.
Yeah.
Live your life.
Yeah. And so that's the nice part about the permanent sterilization, the benefit of that peace of mind that, this is really good form of contraception. I think in a lot of people's mind, they think it's absolutely 100% effective, and it's pretty darn close, but unfortunately,
nothing's 100%.
Just due to statistics, nothing's 100%. And there are some potential risks of failure or pregnancy in, after a tubal ligation procedure. Pretty rare. But that is, we'll just maybe jump into the risks and complications. And so, comparing, because I think it's a good idea to compare female and male sterilization procedures. Actually, data says vasectomy, once you get the confirmatory semen analysis without sperm in it, it's better. We're talking on the order of tenth or 0.1%, or so that would be like 100th. Anyway, 1 in 1,000 more, but
I bet we don't have a lot of male listeners jumping at the.
We're gonna get them.
You think?
This is a
For
podcast
everyone.
in
For
women's
everyone.
health, but for everyone.
It is true.
So we're on call together.
Things get weird.
Yeah. So yeah, 0.1% failure for vasectomy, 0.5% for female sterilization procedures, but that includes all of the ones we talked about, including some of them that maybe weren't as effective. So I'm guessing that actually doing a bilateral self-injectomy or removing the whole tubes is probably very similar.
I mean,
You have to think
through
so.
it,
Yeah.
just how,
Yeah.
Yeah.
So that's a
Immaculate
risk.
conceptions. Just kidding.
Actually, one of the highest percentage risk, I would say, of the procedure. It's not that. It's not, risk of bleeding, infection, damage to any of the surrounding tissues. It's the risk of regret. And someone regretting getting their tubes tied.
Absolutely.
They looked at this in studies, and biggest risk factor was age. And so I think we'll talk more about this procedure in young women as we get along further in this podcast. But for example, in general population in the U.S., if someone's less than 30 years old, you have about a 20% chance of regretting this procedure, and that's pretty high.
And this is even in women who've had multiple children, not just people who have never had children. So even if you had 4, 5, 6 kids, whatever, that risk is still there.
Yeah.
And I think part of it, and this may feel different since you don't have a uterus, it's a permanent thing, right? So it's being able to carry a pregnancy, reproduce, for a lot of women is a defining feature of womanhood, right? And once that option is gone, it's kind of it's a big deal, right? So even if you don't want to have kids, making that big step for a permanent sterilization procedure can be a big deal. And sometimes it does come with regret. So that's definitely something that we always counsel our patients. It's not something to be taken lightly. You have to really think about this and take it seriously.
Yeah. Because one of the questions we get is it's reversible? And we'll talk about that towards the end.
Not the way I do it. It's not.
Yeah, true. We talk about there's other procedural risk, bleeding, infection, damage to surrounding tissues. They talk about this risk of ectopic pregnancy, and I think it's brought up sometimes in counseling, but I think it's interpreted maybe not perfectly, because your risk of pregnancy isn't higher, but if you get a pregnancy after getting your tubes tied, the higher risk of that being an ectopic, because the tube is damaged. And so that's kind of, I think, a topic for the future, but we say that a lot, but we will talk about ectopic pregnancy in the future. But, if there's a damage in that fallopian tube, that pathway, if a pregnancy is going down, it likely is going to stick to that damaged tissue. So that's kind of the hallmark of a ectopic pregnancy. Okay. So, Olga, give me a walkthrough what it might look for someone that is interested in getting a laparoscopic bilateral self-injectomy.
Are we talking about the procedure itself? Okay. Step 1, pick your good music. Make sure
your
you're
subconscious
vibing.
will enjoy it, yes, when you're sleeping.
Absolutely. So laparoscopic sterilization, obviously we do it in the operating room since it is a invasive procedure. The patient is usually / always under anesthesia.
Usually general anesthesia.
Fully asleep, fully paralyzed so that they can't move since we are poking around in a belly.
Quick side note, much different than a vasectomy, in-office procedure.
Patient wide awake.
Yeah, maybe a little pain
though.
relief.
Yeah.
But yeah, go ahead, sorry.
Wondering about their manhood. Once a patient is asleep, we make a very, very tiny incision, about 1/4 of an inch or 5 millimeters in the belly button folds, so that there's a very small minimal scar. And then we put a camera through that port or hole, and then we take a look around the belly after we put a little bit of gas in there, and then we make. Do you do 3 incisions?
Yeah.
Yeah. Another
Some people do 2.
Some people do 2. It's pain and suffering though. 2 other tiny incisions over the hip bones, also about 1/4 inch or 5 millimeters. And then we take a look around the anatomy, lift up one fallopian tube, cut, buzz, cut, buzz. Buzz, cut, buzz, cut. I am getting
If you
tired.
do 2, you have to put a uterine manipulator in.
I don't put one in.
And you do 2?
Oh, we need to do 2?
Yeah.
Oh, I don't do 2.
Yeah, but the people that do have to put a manipulator in.
Yeah. No. And then we pull those tiny little fallopian tubes through those 5 millimeter incisions, take out all the gas, pull out the instruments, and then put tiny little stitches to close those incisions, put some glue on, and then you're done. I mean, legitimately, from start of incision to closure takes 10, maybe 15 minutes. It's a pretty quick procedure.
Yeah.
Honestly, the whole like setup, getting to the hospital, recovery, all that stuff takes a little bit longer, but the procedure itself is pretty quick.
Yeah.
Some people, if you're doing either the fill sheet clips or the cautery, you can get away with only 2 incisions. One would be in the belly button, one over your pubic bone, and that gives you access again to the lower pelvis without having to have multiple incisions. But honestly, the recovery is exactly the same. There isn't a benefit of having 2 versus 3. They're such tiny little holes that you really don't notice any difference. The other option is to do it immediately postpartum. This is not something that we actually offer in our facility, but a lot of facilities do.
Good question to ask, because I think a lot of people like the idea of it.
Absolutely. Typically after delivery, the uterus is still at about the level of the belly button or the umbilicus, so we can have pretty easy access. So we make a small incision about 2 to 3 centimeters, which is about an inch big, along the belly button line, and are able to actually fish the fallopian tube with our finger or a little instrument called a Babcock up, and then either clip or completely remove the fallopian tube, and then do the same thing to the other side, put a couple stitches in, and then you're good to go. And often this is done with just the epidural in place because you already have the anesthesia, or if they don't have the epidural, they go under general anesthesia just like for a laparoscopic.
In that scenario with doing the postpartum one, because you're actually operating with your hands, you can actually tie the tubes. You do the Pomeroy or the blanket on the other method, but Parkland.
Well, you can
method of tying them, and so that's where like the idea of tying the tubes comes from. But you really don't actually tie the tubes laparoscopically in any of the ways.
Oh, that's just pain and suffering.
But patients do actually bring that up, and they're like, no, I want my tubes tied. We're like, no, we're doing the same thing, but so sometimes the idea of, or the terminology tying the tubes, patients sometimes just take that a little too literally, but we kind of use that as an all-encompassing term.
I mean, prior to modern technology, that was really the only option of having your sterilization. So again, culturally, generationally, that's what people tend to hear. So
all right. Well, now that we've gone through a lot of it, I kind of want to bring up these clinical scenarios because there's a couple of points that I want to make, and I do see these scenarios quite a bit. So first scenario, 24-year-old female, she doesn't want kids. She's tried all of these different options. She's frustrated because none of them works, and she's like, I just want my tubes tied. And she's like, is there an age requirement or anything like that? No. I mean, as long as, I think you definitely see out there with people commenting or things like that, like, oh, my doctor wouldn't tie my tubes. He said I was too young, said I needed to have kids. I would never say that.
That's very paternalistic medicine.
Yeah, and there is potentially people that would say that.
But judging you.
Right, or projecting what you should do with your life. In that case, yes, you might need to switch. But also don't take it offensively if your provider, like in the second scenario, wants to really present alternative options. And so 24-year-old, she doesn't want kids. She's really focused on her career, which is perfect if that's what she wants. And, thinking, she'll never want kids. Well, life changes. Things change. Like, how we were so energetic and, going through school and all that stuff. Weren't even thinking about kids. And so, but life changes. And so in this scenario, it's like, well, let's explore something like an IUD. She's like, I don't want an IUD because I don't want kids. I'm like, I understand that. But actually, all these numbers that we present, things like the IUD and the arm implant, statistically are just as good as tying your tubes. And so that's why we sometimes talk with patients and say, let's take a step back. Let's make sure we explore other options because this is permanent. It can't be reversed. And so that's why in that scenario, I just want to bring up, we present other options because, it is a big decision. Yeah. It's not that we think you shouldn't get this done. Right. If we've talked about it and you're still like this, yes, you are an adult. You're able to make that decision about your body, and I respect that. But we're just presenting options, not because we think you're not capable.
So don't be offended if we're still going through all of this data and all of these numbers and all of the options.
Right.
We just want to make sure that you understand what your choices and options are and understand what the consequences are. And like Erin said, you're your own person. You're an adult. You can make your decisions, and we respect that. So I do want to back up. You mentioned as far as the age. I do believe in most states you have to be at least 21
for state insurance.
State insurance, but there's no. I thought it was regardless.
Private
right?
insurance, no,
They don't
it's
care?
a state
Okay,
insurance
all right.
issue. Maybe they would insurance. Yeah. I mean, all other, decision making that comes with that. That's mainly if someone has state insurance, you have a couple more hoops to jump through. Sometimes, unfortunately. To get to sign a piece of paper, and they make us wait 30 days after you sign it. So that's why it's good to, if you're pregnant or at any point, take that into consideration. Oh, I should let my provider know, especially if you're getting a C-section. So you can sign that paper, so it makes you eligible to get your tubes tied during your C-section, if that's what you want.
Absolutely.
One last scenario, again, just to bring up this 45-year-old female. She has a Mirena IUD, and my idea was that, she's not actually, she's like enjoying the lesser bleeding with the IUD. And so she's thinking, yeah, but I know I don't want kids anymore. It's like, again, but the IUD is just as good, and it's giving you that benefit of decreased menstrual bleeding, potentially cramping. Maybe just keep that IUD.
And
Replace
get a
it.
tubal. That's pretty good birth control right
That's
there.
pretty good birth control. A little unnecessary, but
Some people are paranoid.
Always know that if you're taking out your IUD and looking into a tubal, your bleeding patterns might change or increase.
That's a good segue, because I wanted to bring up that something that I always talk to my patients about too is, what are your periods like, and is this a good form of contraception too, aside from lifestyle and whatever and hormonal use? Because if you're using hormonal contraceptives, including a hormonal IUD, because you already also have terrible periods, discontinuing those is not in your best favor, right?
Yeah.
Obviously you can always go back on them for bleeding control.
If after you get tubes tied.
Right.
But then you went through the procedure.
Right,
and
exactly.
it's a little redundant to be
There's
on.
a lot of considerations on that too. So something that we do discuss with patients.
Yeah. It's not that we say, oh, you should stick with this birth control option because I think you're not sure about your childbearing. No, I know that. I'm just saying,
Be
it's
aware.
giving you both.
Yeah. And also let me know in a few months when you're tired of your period, and we can talk about that too.
So yeah, I mean, just quick hit common questions we get. How does tying tubes affect the body? Bleeding problems shouldn't affect it.
Not at all.
As we talked about, the tube is separate part. It connects to the uterus and into the endometrial cavity, but it doesn't have any of the part that gets taken out or clipped or burned. Shouldn't affect your bleeding. What's menstrual bleeding and cramping shouldn't be affected. Your hormones will not change from this.
And again, caveat, if they're previously on hormonal birth control, they'll go back to being natural hormones, right? And then they'll go back to their natural bleeding pattern. So some women will feel that their menses got worse after they got their tubes tied. I keep saying tubes tied, right? But it's really, they're just what they're supposed to be naturally. We were just augmenting them with hormonal birth control. So that's something to always warn patients about too.
That's a good point. And to build off that too, even more, as someone's making that decision potentially in their mid-30s, late 30s, early 40s to tie their tubes, there's also a lot of just physiologic changes that are happening with the ovaries and the hormones decreasing from the ovaries, where someone's bleeding patterns might become irregular to begin with. So it's usually, if you hear about someone saying their bleeding changed after they got their tubes tied, it might just be because of a different complicating factor.
Right. But the procedure itself does not cause that to happen. It's just other body, life, hormonal changes that are causing that difference.
Okay. So one last thing, if someone comes to you and is like, I want my tubes reversed. Well, one, if they had a self-injectomy or their tubes are removed, they can't. But if someone comes to you and they say, I want my tubal reversed, what do you say to them?
I send them to you. Just kidding, I don't.
I would actually, I would love to do the reversal procedure. But one, it's not going to be covered by insurance.
True.
And so it's probably going to be at least $10,000 to just get you in the door in the operating room is like $10,000. And that's like if I do it pro bono, and like everyone else does it pro bono.
Right. Yeah.
And so like to get an operating room is that much money. And then, like not to mention the equipment, things like that.
And it's also not that effective. I believe the data is like 60-70% efficacy after reversal, which is also equivalent to going through in vitro fertilization, which is typically what we would recommend for somebody. So if the outcomes are the same,
and there's a safer option too with in vitro, that risk of ectopic pregnancy is much lower because again, a damaged tube or a repaired tube going to have scar tissue. It's going to get sticky. That egg is going to stick there. And you have a much higher chance of ectopic pregnancy. And so you think you're potentially choosing the right option when, you know, in fact, for a very similar price at that point, and not that that's the biggest factor for all this, but like,
a factor, and for better outcomes. Really.
But we're talking better outcomes, safer outcomes, similar price with IVF. So that's kind of usually the general recommendations. I mean, there can be certain caveats to everything, but
sure.
Yeah.
I mean, I think people that do the procedure regularly have probably better percentages, but again, damaged tube, cost, is it actually going to work?
Yeah.
Is your body able to?
I would warn someone to make sure that they get consults for both REI or the reproductive medicine experts and whoever's saying they can tie your reverse your tubal.
Yeah. So actually what I do here locally is I know the REIs that do reversal, so I send them to those specific infertility specialists so that they can get counseling on both reversal and IVF at the same time. So, but yeah, it's doable. It's just maybe not in your best interest.
That's why we really try to make sure someone is certain when we do it, tie the tubes. So, perfect.
Yeah.
Anything else?
I don't know. What
Back
else
to call.
Want to know about?
Got to answer those text messages.
No, just
go to
work.
a delivery.
Work.
All right.
I'm not ignoring work. They're not emergent.
Yeah, we'll see if we do one more podcast tonight when we're sleep deprived.
I think it'll be really fun.
I do not.
I do. He's being negative. You'll enjoy it.
Thank you everybody for tuning in for today's podcast and potentially viewing on YouTube. If you have any questions, please let us know. As always, the content of this podcast and video are for educational purposes only. None of the content is meant for personal medical advice. Please contact your medical provider if you're in need for personal medical advice. Thank you, everyone. Have a great night.
I find